All right, let's get started. Welcome everyone to our monthly webinar as part of the Health Data Exploration Project. My name is Matt Beets, and I'm going to be introducing everyone today as we get started. And so we have a great panel today. We're going to be talking about, our topic is personal health data landscapes, access, representation, and underserved populations. I'm looking forward to an excellent discussion. The way that today's webinar will work is I'll first quickly introduce everyone who's on the call, and then I will give a short slide presentation just to get us all on the same page with some of the issues that we'll be talking about. And after that, I will open up the floor to our panelists and we'll have a discussion. If anyone has any questions, you can use the Q&A feature in Google Hangouts to ask us questions. We'll be monitoring that so that we can answer the questions that come in from the audience and from people who are online. So, without any further ado, let's get started. Today, like I said, my name is Matthew Beets. I'm a assistant research professor in the Department of Informatics at UC Irvine. And I'm joined today by Margaret McKenna, who's VP Platforms at Runkeeper, where she oversees infrastructure, data, and customer platforms. We also have Donna Sprout-Metz, who is the director of the University of Southern California mHealth Collaboratory at the Dornsife Center for Economic and Social Research. She's also a research professor in psychology and preventative medicine and director of the responsible conduct of research for the Keck School of Medicine at USC. We also have Elaine Nswisi, who is an assistant professor of global health at the Institute for Health Metrics and Evaluation at the University of Washington. And finally, Cinnamon Bloss, who is a assistant professor in the School of Medicine at the University of California, San Diego. Both Cinnamon and I are part of the Health Data Exploration Project that's hosting today's webinar. So welcome everyone. Thanks for joining us. I think this is going to be fun. And let me go into the slides that I have here. Just to set, like I said, just to set the stage for a conversation that we're going to have. All right, so can everyone see my slides? Mm-hmm. Good. Let me start off by saying a little bit about what we mean when we talk about personal health data. There are a lot of terms that get thrown around, but for us, this is a kind of big tent kind of term that really is talking about a lot of the new forms of data that are becoming available around personal, that both have to do with health or say something about our health, but also are collected often at the personal level. And so this also can be seen sometimes in terms like mHealth, mobile health, eHealth. And this slide just gives kind of an example of the range of things that we might be talking about. So you see in the upper left some of the kind of devices, the smart devices, smart scales, smart blood pressure cuffs, but also activity monitors like Fitbit or Jawbone or Garmin's, and data coming from mobile phones that actually have to do with individual health and the sensors that are embedded in those phones. We also have a series of apps that are in this space, Runkeeper, that Margaret is part of, MyFitnessPal, mood monitoring apps, diet apps, things like that. Also a lot of Internet of Things and smart devices that we're going to be seeing showing up. Things like, I know the Sleep Number beds now, many of them are Internet connected and can actually provide data about how well you slept at night. Nest thermostats or smart thermostats, smart fridges that can actually provide data about what kind of food you keep in your refrigerator. And then we have more of the kind of online big data spaces of social media, Facebook, Twitter, etc. A lot of things that are happening in the cloud and with tracking kinds of information, the digital traces that we leave behind, as well as systems like reward cards and other kinds of data that come from how we use our CVS cards or our credit cards, things like that. So this is a pretty big bucket of different kinds of data that we're thinking about within the health data exploration project. And one of the things that we're interested in is, given that these new sources of data are out there, we think that they have some important potential effects on health. And just to outline a few of those, first of all, these new devices, these new forms of data can create paths for reflection and self-improvement. And so we can see things, people wearing Fitbits to help them improve their healthy behaviors and to get out, have a more active lifestyle. But we can also see that in other ways where understanding some of the longer-term trends, being able to reflect over a greater time period with that data can be very helpful. We also see that data being pulled into the clinical context in some ways through mobile health applications and in terms of monitoring chronic diseases. And then also, one of the things that we're particularly interested in with the health data exploration project are ways to create new health knowledge from aggregate data. If we can aggregate these data sources and put them together, it gives us a lot of interesting ways to think about things like, how do we do health research? How do we understand the link, for example, between obesity and diet and sleep? Well, if we've got data that come from a smart scale, an activity monitor, and a smart bed, we can actually get some really interesting knowledge there. We also know that all of these new data streams, whether it's Google searches or Twitter posts or Facebook, can be used for things like public health surveillance and to understand the spread of disease and of public health issues and how those are playing out on a larger scale. And finally, these data can get used for policymaking and planning. And I think we're seeing that more and more as these data make their way out of
I think we're having some technical difficulties at the moment. Just bear with us. With Matt.
Oops, we just lost Matt.
Okay, it seems like he should be back soon. He's given, even in just that short amount of time, I think a nice introduction into some of the issues. I don't know if Margaret or Donna, if either of you want to maybe pick up and just say a few words about some of the issues that he's touched on.
Margaret, you want to start?
Sure. I mean, I think I'm coming from the startup world, so the way that I look at this is a little bit different than an academic or a policy person would. But certainly the trends that Matt is talking about, we see here. So we have about 40 million users, and the kinds of interesting things you can say about or see about fitness behavior when you have a data set that large is pretty cool. Some things like understanding trends around training for a marathon are actually really good use cases for the kind of data that we have. But then when you think about it from a policy perspective, a lot of people approach Runkeeper and say, hey, can we use your data? We want to understand X, Y, and Z about public health. And there's a lot of caveats that come with that because there's many biases in terms of who uses the data, whether it's because of certain populations are using certain kinds of phones, or there's a cultural disposition to a more quantified self-approach to things, or there is just a difference in how people think about exercise. All of those nuanced things we can't see in our data. So if you just take it at face value, then you start to run into trouble. So, an area that I'm interested in is how you can still get value out of a data set like ours, but while being very sensitive to the fact that it is not showing you the full picture.
So I'd love to just jump in on that. Do you have, I've never worked with your data set, do you have gender, ethnicity, age? Do you have those data points or no?
Gender and age, but not ethnicity.
Okay. And of course not socioeconomic status and any.
Yep.
No.
Right.
Although maybe having Runkeeper is already a measure of socioeconomic status.
Well, I think that's an assumption, and we don't know whether that's true anymore. I think Matt jumps back on. It will be interesting to see because I know he's looked at testing the assumption that having access to a smartphone. I'm sure it's tied to socioeconomic class, but it could be that is actually becoming more democratized over time than we think.
Oh, I am sure it is. I mean, if you look at the numbers, it's 68% of all of America, U.S. adults own some kind of smartphone. Or, but in race ethnicity, African Americans are more likely than whites, for instance, to own that kind of implement and smartphones. And when you look at youth, it's almost 90% of 85-90% of African American kids from 13 to 17 own a smartphone. So I think it's definitely become democratized. It's just that I think that they use it differently. Anyway, I hand it back over to Matt. Did we get you back?
Doesn't look like it.
Not quite. Elaine, are you? I can't see you, but are you on?
Yes, I am on.
Do you want to make a few comments?
Sure. So I think we do have similar problems with data that we're getting from sources like Google and Twitter to look at disease spread in the population. So most of this data does not have any demographic information. So most of the time when you're just looking at accounts or people saying I'm sick here, I'm sick there, you don't really know how old they are, or you could get some geolocation information, but not for everyone. It's just a sample of the population that you end up getting.
Mm-hmm. Actually, I mean, I think something. I was sort of thinking about geolocation information when Margaret and Donna were talking, and so it's great that you brought that up. And oftentimes location or zip code, things like that, can be used as proxies for sort of socioeconomic indicators. And so I was sort of curious what, Margaret, for example, what you thought about that in terms of being able to gain some insights into that issue with respect to using your data.
Mm-hmm. Yeah, I mean, certainly we do see pockets of the world where there's no Runkeeper usage. Mm-hmm. And some of those places are, if we think domestically, I'm sure there are some socioeconomic reasons for that.
So it looks like we have that.
I'm sorry about that. It looked like our campus actually, or at least my office, lost connectivity for a couple of minutes. So I'm back now. And hopefully we won't have any other issues. So hopefully you were able to continue the conversation.
Yeah, we just, everybody had a chance to kind of comment on some of the issues that you had raised. But I think if you want to pick up where you left off, that would be great.
Yeah, why don't I just had a couple more slides left that I can go through quickly before we continue. Let me share these again. All right, so okay, so I think I was here when we dropped off. That I was just saying that this is actually thinking about issues about public policy or how these data might be used in the aggregate. This is actually a visualization of some of the running paths that are common in Los Angeles using data from Runkeeper. This was done by Nathan Yao a couple of years ago, but I think is an illustrative kind of way of thinking about how we can understand aggregate level behaviors from these kind of personal data.
Matt, can I just jump in on that one?
Yeah, please do.
That's actually a really good example of how you need to be careful. So that data was, pulled from our public routes information, but without kind of a more nuanced understanding of what it meant. So, for example, public routes, there's certain kinds of people that publish public routes. A route is not an activity. It's I've gone in and this is a place I like to run, so I'm going to record it to use again and again and again, and then I'm going to share it with other people. So what you see there is a very, I would say, biased view of even the Runkeeper data set, which is already biased. So just a note on that, you want to be super careful when you take this kind of data that you're really giving all considerations to, describing everything you know about the data, where it came from, who might have been posting it, so that people who read the map can have a more reasonable understanding of what it means.
Right, and I think that's a great point about these kinds of maps and this kind of data, because what we have is, I think a really compelling kind of visualization here about sort of what it says, but without understanding where that data comes from and what the biases are in both the data set itself, but also in how the data has been selected and presented. It's hard to interpret that data in a useful and accurate way.
Yeah.
And so the other, and I think this also gets to some of what we see in my next slide, which is when we think about who's using these technologies and this data, and this is something that's been known for quite a while around technology adoption in general, that the adoption tends to be unevenly distributed in society, that not everybody adopts at the same rate or the same time. Different communities have different patterns of use, and there are different reasons for that. Sometimes those patterns of use are driven by who has access, both in terms of cost, but also knowledge and how to use those, and the usefulness and usability of those devices for particular communities. We also know that different communities may see benefits differently. There's been some work I know from Pew that has talked about in some of their survey research picking up on differences in the way that African American teens feel about their privacy online. And so understanding how that may affect their use or non-use of particular technologies. And also thinking about personal and collective motivations, that if you're surrounded by people who are using a technology, there may be a different motivation to use that than if you're in a place where not a lot of people are. And so there are a variety of social, economic, technological, and cultural factors that are in play here that may affect who's actually using and getting benefit from the technologies. And this slide, again, it's another example, and again, I think there are all kinds of questions here, like with the previous visualization, about exactly where this data came from and what it means, but this is and I find it to be an interesting map for discussion, because this is data that's a couple of years old that was produced by, and this image was produced by Eric Fisher at Mapbox. But this is actually a map of tweets in the Los Angeles area. And you can actually kind of see the outlines if you know the Los Angeles map. You can sort of see Los Angeles there. But what's interesting about it is that the green dots are tweets that came from Android phones, and the red dots are tweets that came from iPhones.
Oh, that's so cool.
And if you think about this, what you can see is actually that the iPhone usage sort of maps a little bit onto socioeconomic status in the areas of Los Angeles. And so if we think about a technology, a health application, for example, that may only be available on one or the other of the platforms, there can actually be some interesting adoption issues about who is going to get the benefits of that technology and data. So just when we think about this, I think there are two high-level questions here. And first is that, are there people who want or need personal health technologies who aren't getting access to these? And are those patterns of access different from the kinds of patterns that we see that affect traditional healthcare settings? But also, to flip that around, are there ways that these technologies can actually help us address issues of inequality in healthcare? And so one of the other aspects of this is that increasingly these personal data are being used for public policy and research uses. And so what we want is accurate data sets that are really driving those questions, and that affects both knowledge production and social justice. And so just to say what I mean by that is that there's both a question here of, are we convinced or are we certain about the conclusions that we're drawing based on those in a research sense? But also there's a question of someone's ability to be represented. This is a quote from a scholar named Jonas Lerman. And I find this really compelling, this idea that so many people remain on big data's periphery. Their information is not regularly collected or analyzed because they don't engage in the kind of activities that big data is designed to capture. And so their preferences and needs risk being ignored. And so this is a threat not just to privacy, but also to equality in thinking about this. And I find that to be kind of a compelling idea. So finally, couple of open questions about how do personal health technologies affect health opportunities and services and access to those? In what ways might personal health data sets be biased, and how can we address that? And then what advice for the panel would you give to policymakers or researchers who want to use this data? So that's kind of what I have to get us started. And if anybody wants to jump in with a response to those slides or thoughts about them, that would be great.
So those are great slides, and I am echoing, sorry. So something that's kind of dangerous about that lovely light map that you showed, which is so fantastic, is that is already old, and things that I work with underserved populations, and I've seen incredible change in adoption of, for instance, the iPhone.
Yeah, exactly.
Many of the people that I work with are internet or are phone dependent, so they're smartphone dependent. They do not have a computer at home. They access the internet through their smartphones. Like I said before, 90% of youth, of African American youth, and very high percent. I can tell you exactly what percent. Just hold on. So, and 70% of white and Hispanic youth have smartphones. So these are the people. By the time we get our act together, this is the data that we want, because this is the grown-up of tomorrow. And besides, I work with youth, so these are the people that I care about. So the question is not, so do they have access to wearables, to the pretty little things that you showed in your first slides? That they have a lot less access to that. But what they do have is access to wonderful things like Runkeeper, because it's they can have it and they can download it onto their phones. What is biased, I think, in our I think everything that Margaret said was amazing, and I think what's really frightening to me about the way that this data is being used is that it isn't tagged, and if we want it to be informative, we're going to have to get it tagged properly. So at least in some part of the data, we're going to have to ask a few more questions, like we have to know ethnicity, we have to know socioeconomic status. Some things, as we get better with our big data, some things we're going to be able to infer a little bit better. So I think that access is the deal breaker. I think that people are beginning to have access, at least to these small, incredibly smart computers that we all carry around with us. But I don't think that we are getting in there and taking the hard steps to get the data that we need so that we could actually use it. And that is not in the best interests of business, of course. I understand that. So, okay, I will be quiet for a minute.
Elaine, oh, yeah, go ahead, Margaret.
I had a thought in a slightly different direction on the data side, which is just that access isn't just, do I have a piece of technology and am I functionally able to add this app to that piece of technology? It's also, does it occur to me? Do I know about this technology? Do I know what benefits it might give me? Are my friends or family using this kind of technology also? So I think it's important to think about this not just in terms of providing technology, but what's the ecosystem around that? Is my doctor talking to me about using a health tracking app? Am I seeing a commercial for it when I'm watching TV or on Twitter that helps me understand why it would be beneficial?
And do I care? And so you make some really great points. So one of the things that we do in my lab is, and some of the things that I've gotten a lot of pushback for instance, from funders is, when you work with different populations, they're going to need different things, and they're going to want things to look different. Not everything has to be hugely different, but they're going to be things. So they say, but everybody uses an iPhone. And I say, but my iPhone looks like my bedroom slipper because it's highly, highly personalized. So how can we develop these technologies so that they are attractive for people that aren't me? Users should be involved in the development from the bottom up, really. How do we get minority populations and underserved populations interested in using something like Runkeeper? That's a really good question. And there's another opportunity that we haven't touched on yet that I think is really important. And that is something that some of Apple's Health Kit is sort of biting into that could really help us out. And my daughter's a doctor. And one thing she will tell you is, and she works at County Hospital, where many, many underserved come. This is where the uninsured of Los Angeles hang out for health care. And she will tell you that these people are often very poor historians. They're called untrustworthy historians, right? Isn't that right? And having this gives us the opportunity to have data at hand so that your doctor doesn't have to guess. And I think this is a huge possible advantage should we. And the great thing about having something like HealthKit on your phone and having something like all that information in hand so that when your doctor asks you what medications you're using and you don't know, it can save lives. But it can also help to tag the data that's also on my phone if you've gotten me to download something like Runkeeper.
So just real quick, Donna, you've kind of maybe touched on some of this, but I just wanted to mention a question that we just received from Twitter, from Gary Wolf. He says, Donna, do you have a favorite source of demographics for technology use? Obviously there are several, but which do you trust?
Pew. I trust Pew. Hi, Gary. I trust that. I think that they do good work.
Yeah, I agree. Elaine, I wanted to ask you to chime in a little bit as well about some of these questions of how to think about the data that you're getting, because I know you've done a lot of work with some social media sources, Twitter and other things. Can you talk a little bit about how that plays out in your work?
I think if you're looking at data that's been aggregated to the national level or the state level, usually the picture looks really good. But when you start going down to county level or lower, you get a lot of sparse data. And then you start to realize that most of the data that you're getting sometimes is coming from a particular area of the country or a particular set of people. When you have geolocated data, for example, we're doing a study in Brazil looking at dengue. When we aggregate the data at the national level and compare it to reported cases of dengue in Brazil, the correlation is beautiful. But then when you look at the data, when you look at geolocated data, you realize that the data is mostly coming from cities and not so much from other areas of the country. And so there are lots of areas that are very underrepresented in the data. And so one of the things we're thinking about is, instead of just using a single data source, what about integrating different data sources together so that creates a more comprehensive picture of disease in the population?
Can you say a little bit more about that kind of integration? When you integrate different data sources, what are those kinds of sources that you're drawing on?
Yeah. So there was a recent study that was published in 2015, and I think what they did was to look at data from Twitter, electronic health records, data from Google searches online, and I think there was another data source, but I can't remember it. So they try to integrate all those different data sources and use that to model influenza spread and make predictions of influenza over time.
That's really interesting, and that I think opens up sort of another question that I wanted to kind of throw out there, is that I think a lot of these data sets now kind of live in silos.
Mm-hmm.
Yes.
Live, in different corporate databases or different, at the state level. And are there ways that we can think about? Because I know that kind of integration across these different sources is a powerful idea. What can we do to make that better?
Develop ontologies and common data elements, because it's a lovely idea to mesh our data. And boy, talk about siloed data. I worked in a medical school. I'm now in the School of Psychology, but talk about siloed data. But if you don't have common tags, common understandings, and if you don't have common data elements, it's really hard to mesh these data, especially because many of them are anonymized. So I think there's some really great work coming out of a number of people's labs, like Kai Larson, looking at developing ontologies around behavioral health. Medicine is way ahead of us along these lines in the realm of developing ontologies, but even their ontologies are siloed. So I think that's one very important thing, is and I do think meshing these data sets will be really powerful with all the quid pro quos that Margaret.
Margaret, do you have thoughts about that? Building ontologies in, and I know you come out of, you're coming at this from working with Runkeeper. Does that idea of ontologies, does that make sense within the corporate landscape that you see?
Yeah, it makes sense in our own worldview, right? Which is part of the problem. Like, we use, for example, third-party analytics providers. So we have to have a common schema between them. But we, in terms of sort of the content and meat of the data that Runkeeper collects, we don't have the necessity to have a common understanding with other entities.
It's interesting, because I've also worked in different places on the question of developing ontologies, and I know it's that developing them is often the easier part, that actually getting them adopted and used can be the more difficult. And so I think it's a really interesting idea to think about how can we build some momentum around that idea of not just getting the ontologies built, but also out there and adopted.
Yeah, I think you make a good point too, Matt, about the difficulty of actually implementing these things. So I'll give you a simple example. We have an iPhone app and an Android app, and we collect the same kind of data on each one, and it is in our best interest to make it easy for us to analyze across them. And yet, if you look at how these things were actually implemented by individual engineers, it is really hard to match up something that happened in the Android app with something that happened in the iOS app that is supposed to be the same.
Wow.
Wow.
Well, and I know in talking to a number of people about this, just the idea of how is time represented and trying to find a common time point across data sets can be quite difficult.
Correct.
Well, and I think that's where, so Kevin's asked a rhetorical question: is the public health community adapting the use of these data quickly enough, and if not, how do we improve things? Good question. I think that if we hurry to adopt the use of this data without thinking about the stuff that Margaret keeps bringing up so beautifully, and how and Elaine also brought up how dangerous it is to take too much away from this data without having it properly tagged and properly without a proper understanding where the data comes from. That's a little bit. We really have to be careful. I think one of the things, besides the fact that we don't have ontologies that we share, or shared framework for or open mHealth actually, so a shared programming platform, so that we don't get the kind of, I get this. We all of us who work in mobile health understand this problem of the platform problem. But what we also need to think about is how, when we get this data, so Matt, you said something just off the top of your head, and I thought, no, that's not really true. You said we all have to represent this in the same time scale. And I'm saying, no, we have to learn how to model these on multiple scales and multiple dimensions at the same time. And we don't know how to use the data we're getting. Often we do not. It's a new field of developing dynamic models to understand behavior in real time and to understand how all these pieces fit together. And we can't even think about it half of the time. Our minds blow up on these new dimensions.
Yeah, and I think you're right. And I didn't mean to say that we had to put everything in the same time thing, but I know that that's dealing with time is one of the issues that has come up. But I think you're exactly right that often it's not just that the particular term is different, but that in some ways the basic underlying idea of how data are captured or what those data mean is different across different devices, different sensors, different data sources.
Right.
And so that interpretation is something that, it has to be sort of all the way down. I think one of the things that I find that I'm particularly interested in as well is the ways that the design of the sensors that we're using in some of their technological design affects the kind of data that can and can't be collected with those sensors. And as an example, I know, and as somebody who is on the upper end of most scales, it's been interesting to see that a lot of people want to use, for example, Fitbit data to study obesity. But I know from personal experience that that I have trouble finding, for example, wrist-worn sensors that will actually fit around my wrists, or a smart scale that actually has the capacity to weigh people at the upper end of these scales. And so actually there's a technological bias that is built into these data sets that comes from the design of the actual technology itself and can often be easily overlooked when we're thinking about this.
Well, and that, go ahead, Elaine, go ahead.
Do you think that it's well understood that this bias exists, or do people just don't care?
I think there are a number of questions that come up out of this. I think there are some of the biases that are actually harder to understand or quite hidden. And as an example of that, I've been working with some populations of older adults and senior citizens who are using step counters. And I know it seems that some of the algorithms or sensors have trouble with things like shuffling gaits, or with people who don't walk like, or who have an older style of walking, or maybe walking using a walker or a cane. That what a step is in those situations is not quite the same thing as it is for a young athletic person. I also think that these are commercial sensors they are meant for the commercial realm, and so they're targeting, you know, what there's a legitimate question for someone who is in the retail market about where is the cost trade-off between, you know, having a more expensive sensor that can sense a wider range of parameters versus how much they're going to sell from these. And so I think there's also that kind of pressure. For me, it comes down to more of a question of, if we want, again, this is one of those ways that we need to think about how do the data get into the data sets, and what are the parameters that we need to be aware of when we're thinking about using the data set.
Okay. Well, I think this comes back to what I was talking about, user-centered design. You know, the users that industry is centered around, if they even use user-centered design, and they often do better than the researchers, but to be honest, but are not, you know, the underserved. That's not who their market is.
Mm-hmm.
So, and actually, it's not even. If you go, something else that you said, Matt, and that's that people want to use Fitbit for research. It doesn't give you research grade data,
right?
But it certainly gives you a comparison against yourself. So you really have to know what question you're asking.
Yeah.
And also, it's not so much that we would need a more expensive accelerometer, but we would just need to develop a different set of algorithms, and that's expensive in and of itself.
Right.
I just have a quick question. Just at a very high level, a question that's sort of popping into my mind from this discussion is, to what extent do you think these technological advances are exacerbating or making worse existing health disparities, or are they simply perpetuating disparities that exist with more traditional, you know, health research or tools?
IMHO, I think that neither of those. I think that this project can even the playing field if we do it right.
Yeah.
Because everybody has one.
Yeah.
So I don't think it's you know, the other technologies, okay, but this is the important one, because without this one, you can't use the other ones.
Sure. Because I'm just thinking, I mean, you know, Matt, you were talking about scales, smart scales, and I'm thinking like, well, regular scales sort of suffer from the same limitations, right?
Mm-hmm.
So I don't know, just to throw that one out there.
Right. I think for me, again, it's an issue. I think that also I'm of the opinion that I think some of these biases are built into all technologies, that there is no such thing as a purely objective sensor, or a technology or a sensor without a bias in them. I think that we need to be aware of that and work to overcome it. For me, it's uncovering. I think that those biases are going to play out slightly differently, that as we move into a different kind of technological and data ecosystem, that they may not look the same as we've been used to. Issues, you know, we are very much aware of and have done a lot of work around things like gender bias in research. And that's something that has come up a lot and may or may not be something that shows up in these new data sets to the same extent. But it's an open question. What are the issues that will show up? And I think sort of almost kind of having a heedful approach to it, where it's a question that we make sure that we're asking as we deal with the data and as we think about where these are going, of saying, okay, are these introducing new biases, or are they helping us solve them? I think there's a lot of potential in this, exactly what Donna was saying, that there's a huge amount of potential that when you find a new device or a new platform that has as much penetration into the market as mobile phones, and that's not just in the United States but internationally as well, that opens up a huge opportunity to address a lot of this stuff.
Mm-hmm.
Elaine, I wanted to ask you as well, because you've done a lot of this, again, working with this kind of big data, and from my understanding is that your background is on sort of the informatics side. Are there statistical ways that we should be thinking about these data sets that can help us either uncover biases that are in them or deal with them when we find them?
I think first we actually have to identify the biases, and I don't think that's always done, especially in studies where we're just using aggregated data. And I think one of the reasons is because some of that information is just not available. All we get sometimes is just, how many people search for these online, or number of people tweeting about this or that. And we don't have information on gender or age or location in some of those data sets. And so being able to identify those biases in the data is the first step. And then we can think about exactly how we want to represent the observations that we're making from the data. So if we're doing a study where we're mostly capturing data from one part of the country, we cannot just say, the results from that study represent the entire country. It only represents that one part of the country, and then we have to start thinking of ways that these could be extended to other regions of the country. And I think when it comes to data, obviously different people, if you're thinking about social media, different groups of people use different types of social media. And so we want to think about capturing those different groups using those different social media. So if you're looking at data for maybe parts of Africa, for example, there are lots of people that use Facebook, but most of the people don't use Twitter. And so if you want to study a specific population like that, you need to consider data from Facebook and maybe other sources that these people are using. What was the other part of that?
Well, I guess also to expand on this, we've had a question come in that was specifically for you. That's so you're in a prestigious group on health metrics with an excellent track record of informing health policy. And what can you share about how these issues are being factored in as part of in the group that you're part of?
There's been different statistical methods that are being developed to address issues regarding estimates of data across ages and across different populations. Some of the studies we do are focused on estimating disease burden for different countries, and when you look at countries, especially in Africa, there isn't a lot of data. And so we've come up with different methods that we can use to look not only at country estimates, but also regional estimates. So if a neighboring country has a certain incidence or prevalence of a disease, can we use that information to inform us about potential prevalence in the next country?
Yeah, it's also interesting the way that these play out. We've I think in a international context as well, to understand that data landscape is different. It sort of gets even more complicated when we bring in the whole world around this and what happens with data, where we can and can't, where we will and won't find data, or where we will and won't have access to it, but also where those people will actually, what does it mean to have a cell phone in Africa, and the access issues may be different, or the kinds of cell phones, those kinds of things. I remember some questions about what does it mean to have a data plan, and how much data can be shared across that may affect which kinds of apps people are willing to use on their phone and may not.
Yes, sure.
I also wanted to one of the things about this, and this I think maybe Margaret, you brought up this idea earlier, that there's this issue about what is the ecosystem around these, and I'm kind of curious about this. If you guys have any thoughts about the intersection of this kind of personal data with clinical data. Is that a good thing? Is it happening? Are there advances that you're excited about in that space?
Here at USC, we've got oh God, how awful that I'm forgetting their name. But a startup that started here at USC that's working with our health records people to mesh some of the personal data into the health records. We had this really great webinar, panel discussion on machine learning in medicine that was surprisingly well attended. I mean, the room was full and people wouldn't go away and talk for a long time. So that was neat. And finding out what doctors are, what kind of information do they actually want, what do they feel is useful, and what they don't want to be told by a machine, or what they don't want to be automated and what they do want. It's very unclear how to interpret some of this data, as you pointed out, Matt. So if we're going to use something like Fitbit in a health record, the doctor needs some help with interpreting what that might mean for a specific person. So I think we've got a ways to go, but I know it's going to happen. It has to happen, especially coming back to what I said earlier about underserved populations coming to us in an emergency at county hospital, and we have no info. So we'll take anything, but it has to be accurate. It's life or death. So we have to decide what the research questions are, what the kind of noisiness that we're willing to accept in the data, and how to represent that to medical people so that they'll understand what they're looking at.
And Margaret, do you want to maybe chime in on this? I'm just kind of curious if, with your connections in the corporate space, if you see that is a move that people are making, or is that an interest in crossing that gap, or do you feel like they're sort of two different sectors? And where are you seeing that?
So I think, one, it's important to distinguish between the kinds of data that's more medically sensitive, like blood pressure, and the kind of data that is more about your fitness, like whether it's your running data or your step data or even your weight loss data. Yeah. I don't know as much on the blood pressure and beyond side, but I can certainly imagine many use cases for your doctor wanting to integrate like your diet tracker information to the blood pressure system. When I've had occasion to either talk with or overhear people talking about things like integrating Fitbit, it seems like the value is a lot less in the medical providers realm. So what does the doctor actually get out of knowing that you tracked 7,000 steps yesterday? I'm sure there are different use cases. If you're recovering from an injury or a surgery, maybe it's more important. But in the general use case, it's a lot of work for questionable value. The piece that I think is really interesting, and I don't know if anybody's doing work on this, but it's how do technologies like this come up in conversation with your doctor? So my doctor may tell me I should take these vitamins, but it would be great if they also told me, hey, you're trying to watch your weight, you could try this application. Or if you want to make sure that you're getting enough exercise, try one of these applications. Because one thing we certainly notice from our users is that they know their data better than anybody, and the little trends that they see in a graph are things that would not be obvious to somebody who doesn't know them intimately. So, oh yeah, I didn't run last Tuesday because I had to pick my son up from daycare early. We're a long ways away from data knowing that happened, but the individual can make really valuable. So I'm sort of interested in how do we educate people and then empower them to use these tools totally on their own in their own ecosystem, and then hopefully there are positive health effects coming out of that.
Yeah, I think that's a great point too, to think about these not just as sources of data for clinical use, but also as potential, clinical support mechanisms or clinical interventions even, that, helping people understand their own health, giving them the tools to work with. I also think, Margaret, and I want to ask you as well, because I know you've had some experience in sort of the government spaces. Is there an awareness of these issues by policymakers of these kind of bias and representation and access issues that we've been talking about today?
Yeah, so I don't have much experience on the public health side of this.
Right.
But yeah, I mean, anybody who works with large sets of data, you spend enough time with them and you're like, oh yeah, these people are missing, or that kind of activity is missing, or like I think that is well understood.
Mm-hmm. Okay. So we have just a few more minutes. I guess I wanted to give everyone one last chance to chime in, and I guess I would sort of as a kind of I think final question sort of is the open-ended where should we go next question, but I guess more specifically, how should designers, policymakers, researchers, or public health officials who are interested in this space, what do they need to consider? What is the advice that each of you would give them? Elaine, do you want to maybe start off?
Yeah, what we've been talking about all along is the importance of understanding the data. So before you can make any decisions or draw any conclusions, it's very important to understand who is generating that data and where the data is coming from. Yeah, that would be my main advice.
And Margaret?
Yeah, I mean, I think so. Two pieces. One, I would fully echo that. I think there's a lot of excitement about data sets, particularly from the private sector, and people should just be careful about thinking that they're going to solve, X, Y, and Z public policy problem. But the other thing that I think, I've been talking about a little bit is just that in a policy perspective, we should be thinking about what the outcome is. And data and technology is one piece of that, but there's a lot of like human intervention in this too, and how do we think about that?
Great. And Donna?
So I want to, of course, echo what Elaine and Margaret have said about wise use of the data that we have. I think that it would be really fantastic to have a better public-private partnership with, so that researchers could have a hand in helping to make this data less scary, easier, better tagged, or some part of it better tagged, so that we could make some inferences from the data really intelligently. Because I really do worry that without fully understanding this data that we're getting, we're going to make some inferences that are possibly inaccurate. And coming from the other end as an interventionist myself, I think that these new technologies, and in particular the smartphone, brings us an enormous opportunity to serve the underserved. And that too is going to take some kind of public-private partnership, because, as we said earlier, that's not the market. I mean, and that's no blame, no shame, but it isn't the market. And so how do we help that be a viable and vibrant part of what gets developed in the future?
Yeah, and I think I want to say thank you to all of you for joining us today. I think this has been a really fun conversation, and I think for me, I'm both, and I think that we kind of found this, that we share this kind of approach overall, which is I think we're wary about what kind of interpretations about sort of over-expecting from this technology or from this data, but at the same time, I think that it seems that we have a good amount of hope that there are actually good uses that we can, and there are ways that we can actually use this, both to help us know more about human health, but also to help us actually address some of these issues of access and representation and underserved populations around this. And so I hope that we can continue this conversation. I know this is a continuing interest for the Health Data Exploration Network. Cinnamon, did you want to say anything else before we wrap up?
No, just to, like you, thank all of our participants. I think it's been a great, like you said, a great conversation, and kind of thinking through how advances in these technologies can help benefit everyone, and how we can sort of make that happen. So thank you all.
Yeah, so thanks everyone, and thanks for those of you who watched, and take care. Bye-bye.
Thank you. Bye.
Thank you. Bye.